Sustainability, Dr. Chang, who is going to give a brief introduction about why sustainability is important and what is iSustain and what we can learn from what iSustain is doing.
All right, well, thank you, Vinky, and great, my presentation's coming up, and as soon as we can put it up here, perfect. So I'm just going to give a little bit of an overview. I have to leave for another course, and then I'll come back at the end. And I have no financial interest in global warming. So the first question is, why should we care? I push the limits of what we can reuse in the United States, of course, but it's still a huge ton of waste. And we just should all be aware that the WHO has told us that climate is the biggest health threat facing humanity. It's not an infectious disease. And as I think we know, this is going to disproportionately affect those societies, countries, populations least able to deal with the increase in morbidity and mortality. Our own IAPB has highlighted what can happen in eye morbidity and mortality related to the climate crisis. But here's the thing. We are a big cause of that. The healthcare sector, if it were a country, would rank number 5 in the world in terms of carbon emissions. So the healthcare sector is a big contributor to this. The United States is among the worst. Almost 10% of our CO2 emissions are from the healthcare system. And the majority of this is from the manufacture, use, and disposal of supplies. And within healthcare, what's one of the biggest generators of waste? Well, with our volumes now approaching 30 million cases a year, ophthalmology and intravitreal injections is huge. So this was our paper, 2 million consecutive eyes, which we used to show the efficacy of intracameral moxifloxacin, 1 million with and 1 million without. You can get the rate down to 1 per 10,000 with intracameral moxi. And what's notable is that the Aravind Eye Care system, as you'll hear, reuses all of these things. And all of these are in many institutions in the US, and certainly you can't use topical drugs on multiple patients. Everything else we have to throw out each time. Aravind is unique, as you're going to hear, because they actually standardize everything else. So if you take our study and you go back and take the data and just look at you can get the infection rate from what happens when you do 2 million cases and you use all of this stuff that it's illegal for me to use, reuse in the United States. And you get a rate of 4 per 10,000. Remember, half of these eyes had intracameral moxifloxacin. So what is it in the United States where we throw everything out, mandated, in order to make surgery safer? We should be doing much better, right? We're doing exactly the same. This is from the IRIS registry data, overlapping period, 8.5 million consecutive cases. Similar. Some of these are getting intracameral antibiotics, some are not. So let's see. We are spending and wasting 20 times as much. Vinky is going to cover his study about the carbon footprint, and we're getting no value, no safety from that, which is infuriating when you think about what we are wasting. But the optimistic message here is we could cut what we're spending and wasting by a huge amount and not endanger our patients. It won't affect safety. So how controversial is this idea of reusing things? Cassie Teal and I wrote a survey, and we first did this in North America, more than 1,000 respondents. We later did this for the European market, and right after me, Wendy C. is going to give you the preliminary results of our APAO survey. We're using the same questionnaire in all of these. And what we're finding is that, surprisingly, most doctors are, 91% are concerned about global warming. Everyone feels that trash is excessive. We need more reusable, multi-use options. And gosh, manufacturers and regulators should at least let us as ophthalmologists determine what is okay to reuse. Now, we are using intraocular and topical drugs and supply items on multiple patients, and you can go down this list, and this is currently reusing. So intracameral antibiotics and things, 95% of us are willing to reuse. Supply items, including phaco tips and the tubing, and this is important. more than 3 out of 4 are willing to reuse the phaco tubing and irrigating solutions. This is the drapes, okay, whoops, sorry. And this is interesting, okay, so, 2/3 are willing to reuse the gown and not change it after every case. Makes sense, it's clean. This is something else they do at Aravind, and has been copied throughout India, is having multiple patients in the same room. It really improves efficiency, but of course, we're not allowed to do this because of cross-contamination. So this is our study that Dr. Haripriya led, and during COVID, to avoid spreading COVID when they reopened, they adopted these things on the right, which are standard in the West, but weren't at Aravind. So you can then go back and look at, did that improve endophthalmitis? And the answer is it did not. So it means we could move ourselves to all the things on the left, including multiple patients in the OR, and not expect endophthalmitis to increase. COVID also gave us these 5 studies that showed that it's virtually impossible to aerosolize microorganisms with ultrasound and phaco. Again, makes sense because that AC is just filled with sterile irrigation fluid. And this is a study led by Dr. Venkatesh's group, in which we cultured all of these things that are reused. And he'll probably tell you they reuse the same handpiece and tubing and cassette all day long. And if you then culture at the end of the day, more than 3,000 cultures, nothing was positive. So to answer this question, or to look at it, is it dangerous to reuse things? We gave you the expert opinion, which is the surgeons. We've got in vitro data, that huge 10 million patient study. We've got the environmental study, and we've got microbiology. And I guess you could say it doesn't prove there's zero risk, but we can't find any risk that would warrant not allowing ever anything to be reused. So as I look at it, this is what we need to do. There's 3 things. We have to ourselves be educated, and we can do things differently. And then we have industry. They need to do this. And then regulatory agencies need to understand that eye surgery is different from general surgery and orthopedics. So we have founded a coalition called AIOS2025, and it is co-anchored by ASCRS, ESCRS, and the Academy. Those are the sponsors, and we've just now added EU Retina, the largest retina society in Europe. Each society has its own committee, its own page on this. But to this now, we've added 53 global member societies as part of this coalition, all devoted to collaborating on reducing our carbon footprint. And it spans the world. It includes, here's our member list. So there you see AIOS, and Venki is one of the reps, and then APAO. We have an advisory board, we have an editorial board, which is going to be reorganized. It's half European, half American. We welcome Asians. We have our own app. And this is where you can come to find the latest in publications, latest in news, and then whether it's the OR, the clinic, drug waste, and then the section on low to middle income countries, we have sections really to highlight what can be done in each of these areas. And wherever possible, we have the evidence linked to it, because if you want to go to your hospital to have something changed, you need evidence. You can't just say, we want to change this. We're building a retina section, and this is very important because intravitreal injections, the numbers are staggering in terms of how many are being done, and there's huge waste there. Now, this surgical facility pledge is something I would love everyone here to do. And it's like signing a petition. No one's going to ask you to follow up. But these are 7 things that we can all do now to cut our carbon footprint. And if you go to AIOS2025.org, you'll see the 7-point pledge. And almost every one of these saves money. Some of this is just education. This is ESCRS created this tool that we have online where it helps you understand how much waste is generated by each item. So if you're not using it every time, hey, get rid of it, save some money as well as waste. This is reusing topical drugs, the necessity of, you don't need a full body gown. You just use a plastic drape. This is using reusable things, using alcohol-based surgical scrub. And we would love if you could get your facility to just put the name on there. It's a petition. No one's going to check on that, but then we add you to this banner. And we would love to add your facility here, kind of like signing a petition that says, hey, we are committed to looking at ways to save money and carbon footprint by eliminating things that aren't necessary. And if we can all do that. We succeeded at getting the academy to including sustainability in the basic science course. And we now have the American Board of Ophthalmology adding sustainability questions to the board exam. So this now becomes something that residents should learn about because it affects our patients. All right, the second thing is industry, all right? So we have a section called Industry Initiatives. We put together an industry advisory board because we think that collaboration is important, but very importantly, though, we don't accept any money from industry for the website. It's covered by those 4 societies because we don't want any conflict of interest. You know, one of the things, easy, there is no reason there should be a paper instruction for use with every IOL cartridge and IOL. Come on. So we put a multi-society position paper calling for EIFU across the board for ophthalmology, but prioritizing those things used on every case. It's a little complicated because there are regulations and so forth, but we're working on that. And all of our position papers, we have 3 now, are there, okay? So this is, again, a toolkit because if you want to, you know, talk to your facility about short cycle flash sterilization, there's a position paper for that. This is IOL packaging. This is a study that John Hovannesi and I did. And this is just showing the huge variation in the packaging weight and sizes of the boxes for IOLs. That's obviously bigger with a preloaded system. And this is working. One company that makes the adjustable lens, they came out with a smaller box because they had the biggest box, and we told them that. Alcon is you're going to see already a smaller box that's going to get even smaller next year. I switched to the only phaco machine in the United States that allows us to use reusable tubing. We have to process it and autoclave it. But now 1 cassette takes the place of 20 plastic cassettes and packaging there. But what we're really calling for, and we're working on a position paper, calling for the phaco industry to get away from this throw it out each time. This could be autoclavable, but the best thing would be to have an all-day cassette that you don't take off and have them charge a click fee or do something so that they can collect a reasonable amount of revenue, but they're going to save so much in terms of manufacture costs, raw materials, shipping, and packaging that there should be savings that they can pass along to us. They can make a similar profit, but why have to throw this plastic, which is not recyclable, goes into landfill, and becomes part of the microplastic problem we have. Regulatory is the last, and that's the trickiest question. And, you know, we get into problems because by default, we have to follow general regulations that are set up for general surgery. The classic one was when we were told we could not use flash or short cycle sterilization for cataract instruments, meaning a 1-hour wrapped sterile cycle for every tray. We'd need, you know, 20 to 30 trays just to get through the day. Nick Mamelis and I chaired a task force where we actually wrote ophthalmology-specific guidelines. It took us 3 years to do this, but you got to do it because if you don't have your own guidelines, you have to follow the others. So again, this is a position paper on iSustain. It turns out that there is just no evidence behind most of these guidelines. It's expert committees who obviously have a bias because they're nursing infection control nurses. This is a classic what we call eminence versus evidence-based. But there are regulations, so we have to come up with evidence, like some of the ones I just showed you generated from Aravind. And then you have hospital regulations, and they're worried about liability and things like that. So you just need to go up with that. This is documenting the cost as well as the carbon footprint of unused topical drops. and yet there are many hospitals that require you to throw it out after a single use. So we had to generate our own position paper saying that everyone should, unless you contaminate the tip, reuse the bottle until the date of expiration. We were able to get the government, it's called Medicare in the United States, to change the rule where they said you can't keep a bottle for more than 30 days. Now we can keep it until the date of expiration. Alrighty, if it's frozen up here, thank you. Yeah, can you just let me, since the last course went over half an hour, can you free up the, do I have to, thank you. All right, so the label, here's the other big problem. In order to be able to reuse something, the company has to show that it's safe to use it 20 times, and then it can be labeled, you can reuse it 10 times. All right, so that's hard. But if the company doesn't do that, you by default get a single-use label. And of course, look, what reason would a company have to go through all that, to validate that? But then the default is you can never reuse it. That's a problem. So I organized both the Academy and the ASRS to talk to different people at the FDA. And we said, you need a new label. You know, tell us when we shouldn't reuse it. I want to know that. Tell us if the company validated that you can reuse it. But the default should be nobody's validated reuse. Then it becomes my decision to do it off-label. And that's what we're trying to push. It allows for off-label use. This is my congresswoman who's very influential, and with her help, we met with CMS to try to get some relief. So this is the tough part, is working, you know, on the regulatory side. So I'm going to end by basically saying, you know, we all know usually ophthalmology, no one cares about that in terms of general medicine, but our volumes are staggering. And so we actually have an amazing opportunity as well as an obligation because of the volumes, because of knowing from the Yerevan studies that it's safe to reuse things, you know, to do something, you know, about that. And so as we get the next speaker up, you know, Dr. Venkatesh and I go back 22 years, and I have learned so many things from Yerevan. Dr. Ravi's here. We also met 22 years ago. And I didn't know anything about this until they did the studies. So they kind of, like a lot of things, got me started on this. And thank you all for being here. Thank you.